with particular reference to the Watchman device, and I'll explain a little bit about what that is. And then I was going to try and show echo images just to sort of, let us have a look at some of the toe pictures from Watchman device implants and kind of what we're looking for during those procedures, and also in the assessment pre and post. The main thing you notice from this slide is the thumbs up, which is not because it's a cool slide, it's just because your left atrial appendage is a little, outpouching off the side of the atrium, which I'm sure you guys are familiar with, although as you know, you don't really see it on transthoracic echocardiography, and it's mainly on toe. It's about the size of your thumb, and it's got quite a number of different shapes, and one study classified it into these 4 different shapes: a cactus, a chicken wing, a cauliflower, which is a rarer one, and a windsock, that should say. But you can come up with your own names, and some of you might have a few ideas based on the shape of those as to some alternatives. So the commonest ones are these top 2, and I guess one thing that I've learnt from trying to block these left atrial appendages off, which is the idea of a Watchman device, is how different they are, not only in the shape but also where it actually comes off the heart. And sometimes it's more lateral, sometimes it's more anterior, and it does make a difference to how you do the procedure depending on where the thing is. So I guess that's the simple kind of view of it, a little pocket sticking off the side of the heart. Its embryological origin is that it's the sort of fetal left atrium, and it doesn't seem to have any purpose in the adult heart apart from forming clots within it and causing stroke in people who have atrial fibrillation. So, in people who don't have valvular heart disease, about 90% of left atrial clots from atrial fibrillation form in the left atrial appendage. And I think it's probably higher than that. The only time I've ever seen clots anywhere else in the left atrium is in people with mitral stenosis. I don't know what you guys think, but they don't seem to form anywhere else from what I've seen. And you can see that's a nice big chunky clotting, and I'll use the laser, a nice big chunky thrombus sitting in the left atrial appendage. You can see the shape of this one coming down, and you can maybe appreciate there's a bit of spontaneous echo contrast, sitting up here to give us an idea of stagnation of blood and clot. So the idea of the Watchman device is to plug this appendage off so that any clot that forms in the appendage can't get out and cause a stroke. And it's mainly the technique's mainly done in people who can't be anticoagulated for some reason. So normally to stop those clots from forming, we put the patients on warfarin, or now we might use some of the newer agents like Pradaxa and Xarelto and Eliquis, the new anticoagulants. But not everyone can have them, and as you know, there are some people who have bleeding problems, and I just saw a patient before I came here this afternoon who's now been in hospital 3 times in the last 3 months with gastrointestinal bleeding, on warfarin, in AF, diabetic, very high risk of having a stroke, but really can't be on warfarin because they're just having recurrent bleeding complications. And the new blood thinners don't fix that problem. I mean, you're just as likely to bleed on the new ones as you are on warfarin. In fact, possibly they may be worse for that. So there's going to be a little group of patients who ought to be anticoagulated but can't be, and this is where the Watchman device might come in. So this is just an angiographic image just to kind of demonstrate in another imaging modality how the appendage can look, and you can see that one looks like what you expect the left atrial appendage to look like, and this one, it's a big long curly thing that comes down and then wraps around and ends up here. It almost turns back on itself. So they really can be quite different in how they look. And the understanding of the shape of it can be difficult to work out on toe because, and I'll run through some views that help us to try and figure out what the actual anatomy of the appendage is on the transesophageal echo a bit later on. But that's kind of the concept. The device sits near the mouth of the appendage. It's got a filter over the top of it which actually gets endothelialized and blocks the appendage off. But you might say, okay, it's in the left atrium, how are we going to get it in there? And it's inserted through the femoral vein You then do a transeptal puncture through the interatrial septum, and then deploy the device in the appendage. So there's a couple of different parts to the procedure. One is getting across the septum, and then getting your catheters into the appendage, getting everything in the right spot, and releasing the device. I think, I'm sure a number of you are involved with transesophageal echo in the hospital setting, and I think you're probably seeing more and more toes being done for crossing the interatrial septum, both for this sort of procedure as well as for the stuff that Michael does, ablating atrial fibrillation in particular. So I've got, this takes 55 seconds, because I know I used to hate it when anyone put a video slide up, but this is basically the concept. So the catheter goes through the interatrial septum, you then park a wire up in the left upper pulmonary vein, bring in the bigger delivery catheter, and then you pop a pigtail catheter up there, which is softer and safer to manipulate, move that into the left atrial appendage, and then you bring the delivery catheter into the appendage, take some pictures, make sure you're happy with where it is, and then you can do some measurements, pick the right size device, and sort of unleash it, and it forms like that. And you can then do a tug test to make sure that it's stable, do some angiography and some echo images, unscrew it when you're happy, and then you'll see how quickly it endothelializes in a second. But it actually takes probably a couple of months for this to happen, but just, so that's basically what a Watchman procedure is. So I guess remember this bendy appendage that I showed you before, this funny looking one that curls back on itself? That's the same one after the Watchman device has just been deployed. So you can see it's blocked it off. The appendage should be coming around here, and it's now nicely occluded. And you can see I've still got the thing on the end of the delivery cable, so it often causes it to occlude really quickly, during the procedure. And you can see the transesophageal echo probe. And actually, while I've got this one on here, when you're doing the transesophageal echo to look at the left atrial appendage, this is about where you want to be. You don't want to be high up and looking down on the appendage. You get bad pictures of it that way. It's best to have the probe deep and flexed and looking back up at the appendage, and then basically you're shining your ultrasound at the appendage, and that gives you much better views. So what I sometimes do, and maybe something to quietly suggest to a struggling cardiologist trying to get some views of the appendage, is get the proceduralist to screen for you and show you where your probe is on the X-ray screen, and then put it there basically. And if you can, sometimes you say, oh gee, I'm really high, and I need to advance the probe, or maybe I'm too deep. But if the patient's sitting there in a cath lab, you might as well screen it, and have a look. So I actually do that quite a bit when I'm doing toes during Watchman implants, because I'm one of these weird people who implants them as well as doing the toes, which apparently is abnormal. That's just what the Watchman device looks like. There's another device too called a cardiac plug, which is the same concept but a slightly different shaped device, but I won't talk about that one tonight. So look, we end up doing three toes in these patients. One is done before the procedure to check the anatomy, make sure the thing is the right dimensions for closure, because there aren't unlimited sizes of these devices. And also to make sure there's not a thrombus in the appendage, because you don't want to be poking your catheter around in there, manipulating things inside the left atrial appendage if there's a thrombus in there. So it's crucial to check that both before you decide you're going to do it, and then again on the day you do it. The other thing is to try and figure out where the appendage is on the heart, because that might make you decide to use a different delivery catheter depending on where the appendage comes off. Some of them are sort of very sort of superior on the heart, and some are more lateral. And if you're sort of anterior, you want a double curved catheter, and if you're lateral, a single curved catheter will actually be better. It's a little bit hard to get that appreciation on toe, but there are some tricks to it. But CT is extremely good, and I think a lot of people are using CT as well as toe to to look at the left atrium when doing these kind of procedures. And I think in the EP world, there's a fair bit of left atrial CT that goes on, as well as electrical mapping of the left atrium to try and understand where the veins are and where the appendage is and that sort of thing. So the sizing I've mentioned, it's nice to document whether or not there's a pericardial effusion before you start fiddling around in the heart, because of course one of the complications from poking catheters around in the left atrial appendage is it's quite thin-walled. If you perforate it, you can cause a pericardial effusion, and it's very nice to know whether there was one there beforehand or not, because otherwise you're going to see one during the case and then be anxious that you've done something you shouldn't have. So always have a look at that before, during and after. And the other thing is to get some shots of the interatrial septum, because you're going to need to go across it with the catheter, and it's nice to have a look at it beforehand, and it can sometimes help decide what sort of transseptal catheter you might want to use, depending on whether it's a really floppy redundant septum or whether it's a nice stiff kind of flat septum. So this was just a CT shot. So this is kind of a left atrial CT, and this is the left atrial appendage coming off here. So in this guy, I found the CT quite useful because it told me, okay, I haven't got much, I need the thing to be sitting about here, the Watchman, and I haven't got, even though the appendage is quite long, if you do the measurements of it, it's quite long. That length is not going to be usable for where my device is going to end up. I've only got that little bit there to play with, because basically it comes out and then turns a 90-degree bend. So little bits of information like that can be helpful when you're planning it. And just because they're all different, it's good. I mean, it makes it interesting, but on the other hand, it's probably worthwhile having that kind of information before you start doing the procedure. And I can probably show you, but these CTs you can play with really. So I guess this different shaped catheter might be used depending on what you're trying to do. So anyway, enough of that sort of talk. We probably should show some echo images, but shouldn't we? So that's the left atrial appendage, and we like to take measurements of it in 4 different views. Firstly, with the multiplane at 0 degrees, and then again at 45, 90, and 135. And you learn different things from the different views. In each one, we measure the diameter, which is supposed to be done at the level of the circumflex artery. That's the circumflex coronary artery sitting there. And that line maybe I might have drawn up there, but and then the length from basically the midpoint of that line that you draw, we then do a length down to the tip of the appendage and record those numbers in the 4 different views. And that gives you an idea of what the diameter of the appendage is, how much landing zone you're going to have to put a device in. A Watchman device is as long as it is in diameter, so there has to be more length than diameter to be able to put one in. And also it gives you a bit of an idea of whether the orifice is actually round, and it's usually not. And so you need to take that into consideration when you're sizing the device. So I think I've got a couple more pictures. This is the same appendage. I think this is the 0 degree view. That's 45 degrees. And then you can see at 90 degrees, this is the appendage here. And then 135 degrees is a weird view. You often start doing and think, why am I looking in 135 degrees? Because it's very foreshortened, the appendage. But it's really good at aligning your delivery catheter, because basically however your catheter comes in on that 135 degree view is going to be how the device ends up. And so even though it's sort of not that useful usually for measuring depth, it's very useful during the procedure to be seeing that view. Now, as I mentioned, the first part of the procedure is getting across the interatrial septum. And it's really nice if you can do this under transesophageal echo guidance, because you know exactly where you are. And I think the best views to have up are basically a double. I guess the other thing I haven't mentioned is really the 3D imaging is, I think, pretty critical for these structural cases. I mean, you can do it without it, but it's much nicer to have a 3D machine that's able to give you 2 planes in real time. So here I'm looking at at about 42 degrees, which gives you and that's the interatrial septum there, aortic valve. So this is basically the anterior end of the septum, and that's the posterior end. And then in this view, if you rotate your toe probe a little bit clockwise, you pick up this bicaval view, where you've got the superior vena cava here and the inferior vena cava here, and there's the thin part of the interatrial septum there where you want to puncture. So this, if you keep it in that view, while the procedure's taking place, you can, the catheter's normally positioned up in the superior vena cava, and then we drag it back until we hit the fossa ovalis to cross. And so you can watch it coming down. You can see the catheter on here, and it'll gradually drag its way down, and you can say to the proceduralist, okay, you're in the right spot. And for these Watchmans, we usually want to try and cross posteriorly and inferiorly, so that we're sort of at the back part of the interatrial septum, and then the catheter comes up anteriorly and superiorly into the appendage. So there is a kind of bit of 3D anatomy learning that needs to happen, so you can kind of visualize what you're trying to achieve. And so this next slide is just the needle going across. So I don't know if you can make out here, but this is the septum, and you can see it's being tented by the needle for the first part of the loop, and then it stops tenting because the needle's gone through. So, and there's the shadow of the needle sitting in the left atrium. And obviously you don't want to put the needle into the aorta, and you don't want to put it out the back wall either. So that's not bad. It's fairly posterior there. It's pretty sort of, I guess it's a little bit inferior, from superior to inferior. So the spot where that needle's gone across is not too bad for a Watchman. But you can see how usually it's really clear, and people get anxious about crossing the interatrial septum because they're worried they're going to poke the needle somewhere they shouldn't. But with toe guidance, it's usually pretty quick and straightforward. And I must say, I know that a lot of it gets done just using, just using angiographic landmarks on the II screen. A lot of transseptal puncture around the world happens in that way. But I must say, I always feel very happy to have the toe there and know exactly where the needle's going. So now this one, that's the transseptal catheter across the interatrial septum, and it's sitting in the left atrium. And then now it's been moved up into the left upper pulmonary vein. I'll just try and orientate you here. So there's the mitral valve, left ventricle. There's the left atrial appendage. You can see the spontaneous echo contrast swirling around in there. And that's the left upper pulmonary vein there. And we park the catheter up in there to exchange over to the bigger delivery system. It's a safer place to leave catheters sitting rather than in the appendage, because you don't want to be poking around in the left atrial appendage if you can avoid it. So you can see during the case, it's really helpful to have pictures so that you can see where the catheters are, help the proceduralist and say, okay, you're in the left upper pulmonary vein now, so they know, or you're in the appendage now and you don't want to be, kind of thing. And so I think that communication between the echo team and the interventional team is really critical for these. So this is now, what have I got here? Oh, this is a sort of double plane view. So this is the left atrial appendage here, and you can see the delivery catheter is now sitting right down in the appendage, which is where it needs to be. And this is my favourite 135 degree view, and you can see the catheters coming down quite nicely into the appendage and sitting coaxially with the appendage. The main problem you have with these Watchmans is if that thing's coming in at a really skew angle, then basically the device is going to end up coming out perpendicular to the plane of that catheter, and if it's off angle, your device is going to sit out with the shoulder, and not sit nicely in the appendage. So I think this kind of view is great. Having both pictures up, the biplanar view is really useful for these. And then you can do some nice 3D. I mean, there's the delivery catheter going down into the appendage. Hard to know how useful that sort of imaging is during the case. It's probably, the biplane stuff's probably more useful, but it's hard to resist, isn't it, when you've got pictures like that.
Just before you go on, are there any specific degrees that we should be looking at or measuring through? For the plane, yeah. Look, I think when you're, I think
you probably want, during the kind of catheter manipulation device deployment phase, that's not a bad couple of views to have up. You basically want an orthogonal view, so probably the 135-degree view and a 45-degree view up together is probably ideal, because then you can see basically where you are in the two orthogonal planes, and that's usually what you need to know. You're looking at it on II as well, you know, and injecting contrast, so it all comes together. And I must say, it is good to have the two images up on the one big screen, you know, in these new cath labs that have got the big monitors and you can have the echo picture and the II next to each other. It really helps. Okay, did that answer your question, Sharon? Yes. Yep. So this is now a Watchman that's just been deployed. So that's actually the Watchman there. They look a bit like a strawberry. And what's happened in this one is, and it's what seems to happen with these a lot actually, is you end up being deeper than you think you are. We're always worried we don't have enough depth, and oh gee, you know, we're going to run it, you know, there's not enough depth to fit the thing in. And usually you deploy it and find out you're too deep, you know, you're sort of, oh, what was I worried about? And you can see this one, it hasn't really formed, it hasn't opened up properly. See, there's a gap here on the left-hand side of it. And I think the reason for that is the feet, you know, the metal, it's a metal frame with little feet. I don't think they've been allowed to open up fully. And the tip of the feet are actually constrained down here in some of the pectinate folds of the appendage, and the device isn't really right. So this is the kind of thing where you have to say, hang on, this doesn't look right. You might want to put the colour flow on and show that there's colour, you know, tracking down here around the edge of the device, which there's going to be. And then the proceduralist needs to say, okay, that's not good. So now this is the same thing in another view. So you can see again, gap around the device, doesn't look like it's opening up properly. So there's a problem. So basically what happened is the device was partially recaptured and then withdrawn. And you can see now that it's opened up properly. You can see the feet are a lot wider apart than they were. The device is nicely pressed out against the wall of the appendage, and it all looks much better. So that's what they kind of look like. And then the things we really want to know once it's deployed is has it opened properly? Is there a gap around the outside of it? Is there colour flow around it? And then also, how big is it? Because we want it to be compressed by sort of 8 to 20% of the size. So if it's a 30 millimetre device, you don't want to be measuring 30. You want it to be, say, 25 once it's deployed, so you know it's, you know, pushing out against the appendage, it's not going to fall out. And the place to measure it is, I don't know if I can freeze that. Let me see if I can. Yeah. Maybe. Well, that's not the ideal shot, but basically you want a shot where you can see the little stalk where the delivery wire hangs on, and you can see the edges of the device, the kind of shoulder, so it comes out there and gets widest about there. And you want to be measuring from there to get the diameter of your deployed device. So you need to get a shot where you can see the stalk bit, which is the centre, so that you know you're not measuring it off axis. Otherwise you could be just cutting through the side of the device and not have any idea how big it is. So look, these are kind of the, you know, release criteria for when it's okay to let go of the Watchman. One is the position. The second is the anchor, so whether it's stable, and you can do a tug test. I think I've got a slide of that. The size, the compression we just mentioned, and then the seal. You know, is there leakage around the edge of the device? So this is a sort of slide showing the device position, just at there's the circumflex coronary artery there. The device is sitting just nicely at the mouth of the appendage. And here's a tug test, so you can see the proceduralist is pulling on the thing a bit, and it's staying stable, and it sort of pops back into where it was. That's probably a little bit more of an aggressive tug test than ideal. Might have been one of our early ones. And here's a slide. I didn't realise I had this one, sorry, but this is where you should be measuring. So you can see there's that central screw bit there where the delivery cable goes on, and you can see the shoulders of the device there, and that's what it looks like on the toe. So that's a nice position for doing your diameter measurements. And then we do that in the 0 degrees, 45, 90 and 135, and get and have a look in all 4 views at the size and for colour flow around the edge. And for Watchman, colour flow of less than 3 millimetres in width at the narrowest kind of point is acceptable, and usually that will seal itself over with time. Okay, and here are some measurements taking place. So, yeah, as we've been discussing, in the 4 different views. So here we've got the colour flow on. There's the Watchman device sitting up there. Doesn't look like there's any colour flow around the edge of the device, which is nice. And so this is kind of the situation we want to be in if we're going to deploy it. It's not unreasonable to have a bit of 3D or 4D imaging prior to releasing the thing. So here you can see the Watchman device sitting quite nicely at the mouth of the left atrial appendage. That's the delivery cable coming off it still. And, these pictures probably are helpful and do allow you to see that the device is seated properly, that it's not canted and that it's not poking out more than it should be. And then I think the next slide is after the cable's been released, and that's the device still sitting in the appendage, which is always a very good start, and but looking quite nice. So, and then I think afterwards, check the device is stable, check the pericardium and make sure it looks empty, and then in the protocol for the Watchman, they all have a 45-day post echo to re-look at it, make sure that position's correct, size is correct, look for a leak, and if all those things are okay, the patient can then come off warfarin, so they end up with the 3, a toe beforehand, a toe during, and a toe at 45 days. And this is what happens to them. This is a dog that's had it implanted. Sorry, the dog didn't live beyond 45 days, but you can see it does get endothelialized pretty well. And this is a human specimen of someone who died at 9 months after the device, not related to the device implant. And you can see it is actually quite nicely covered over. You can just see that little delivery nubbin, where the cable screws in, but it looks pretty good. So it's surprising that they really, you kind of think, oh yeah, they're going to endothelialize, but they do endothelialize. So that's all I got for you guys. Happy to take any questions. Hopefully that's just given a couple of ideas about what you might be looking for on the echoes during these kind of procedures. Yeah. I think the 135 degree is good post-deployment because it's often the one that will show you if there's a shoulder of the device sticking out. I probably should have put up some slides of some that don't look good, that we've recaptured and redone, because when they don't look good, often what you'll see is that, in that 135 degree view, you can see the opening of the appendage, and then you might see the device is sitting like this, instead of in the right plane. And that often does show up best in that 135 degree view. The other views often make it look better than it really is, and it's not till you get around to the 135 that you go, okay, it doesn't look so good. The cloth, it all hinges on the cloth. The cloth goes halfway down. So if you've got a 21 millimetre device, you've got about 10 millimetres of cloth down the sides. So in theory, you can have somewhere close to 10 millimetres of shoulder, and it'll still be covered, and then it'll endothelialize over the top. So, look, we have had some where the best position we could get had a shoulder that was fairly significant, but looking at them all on the 45-day toes, they've looked fine and the patients have done well. So it's, as long as the shoulder's less than half the length, it's okay, and as long as there's no colour flow. So I guess you want to be, if it does look like the thing's canted, you need to be extra careful and make sure you've really had a good look for a leak around the outside. Yeah, that's right. So you put the colour on and then try and freeze it on the frame where you can see the colour, coming out along the edge of it, and then you want to measure the narrowest point of that colour flow, and that should be less than 3 millimetres. And if it is, it's considered acceptable. That was what they used in their trials as the cut-off, and they got good results in the trial for stroke risk. Yeah.
What do you use
Yeah.
as your setting?
Yeah, you need to. I just can't remember off the top of my head, but they did specify that in the trial. There was a Nyquist limit for that they specified, but I can't tell you what the actual number was. I'm sorry, but it is set as a specific one. Well, that's right. Otherwise, you can make it whatever you want. Yeah. Make it 3 millimeters, Sharon. You need that's one of the key things you're looking for is there thrombus on the device. Ideally, you want them on warfarin for 6 weeks until they have that 45-day tow, and then after that they can switch over to aspirin and Plavix if it looks okay. Not all the patients we've done have been on warfarin because some can't be. You know, some have had intracranial hemorrhages and all sorts of bleeding complications and basically just can't be on warfarin. And so far we haven't seen any trouble, but there are certainly case reports out there of thrombus on the device, and this is part of the reason why you do the 45-day tow. So if you can, you have them on warfarin for 6 weeks afterwards, therapeutic INR, do the tow, make sure it looks okay, and then you can change the anticoagulation after that. Doesn't seem to be. I mean, I think the theory is hopefully it's endothelialized by that stage and it's not as thrombogenic. I mean, you can't really see the endothelialization on the toe, unfortunately, you know, because the imaging is just not able to show that. But yeah, the stroke rates in the trial that was done were very low, you know, back down to kind of expected for the population levels of 1% annual risk of stroke using that routine. So they did another study looking at patients who couldn't be on warfarin. In those ones, they tried to put them on aspirin and Plavix for 6 months post, and then just on to aspirin after that. And the stroke rates were still pretty good in that one as well. 6 months and then aspirin after that. So if there's not sort of major contraindications to anticoagulation, you can do that. Our real-world experience is that most of them, the reason they're having the procedure is they've had major bleeding troubles, and so we've done some on nothing. You know, the patient's been on nothing. We just put the thing in, and so far they've been okay. They remain in AF, so it does nothing to fix the AF. Yeah, I think I don't think it would be likely to interfere with EP procedures because you know you can still get to the pulmonary veins and all that sort of thing, even with a Watchman device in there. You can do MRI scans with them in as well. They're MRI compatible, so there aren't too many problems. I guess there's probably more problems with septal devices, you know, causing trouble, but the Watchman shouldn't be as much of an issue in that regard. Very interesting. It's an interesting question because the surgeons, if you look at the data on how well the surgeons chop off the left atrial appendage, if you ask them to chop it off, their results are woeful. They have about a 50% success rate, you know, and you sort of think, how can that be? You know, you're there, you got the appendage sticking off the heart, you chop it off, but the problem is they don't chop it off. What they usually do is they put a stitch around it and pull it tight or something like that, and what that usually does is it doesn't completely close it, just makes a nice narrow neck at the top, you know what I mean? So there's even more stasis of blood in there, and so I don't know. I think if the surgeons do it properly, and by properly that probably means opening the left atrium and actually closing the thing, stitching it from the inside, you know, so that you can see that you've closed it. Yeah, that's right. So I think if you're doing a mitral valve procedure and left atrium's open, yes, the surgeons should be chopping them off and properly closing them. But I think a sort of drive-by, you've had a bypass, I'll put a purse string round your appendage and pull it tight. That's not a good solution. So I've done a number of tows on people who have supposedly had their left atrial appendage amputated at the time of cardiac surgery, and there's still a left atrial appendage there. So it's hard to recommend surgical closure when their results are so bad. But on the other hand, I think if it's done properly, and particularly in mitral valve procedures, yeah, that's right. They can make sure they've actually done it. But yeah, so it's surprising. But there are a couple of new surgical devices that to assist them, you know, that sort of like suture zipper devices, which you can sort of put it across and it does a multi-stitch across it, and then you can zip it off. These kind of things. But having spoken to a few of the surgeons about it and asked them why they can't close them, the surgeons say if you want to do it properly, you have to open the atrium and sew it closed from the inside. And the problem is that that's not usually what interfering with the mitral leaflet with the device. But I guess but it's not usually a big issue. Yeah, Apara.
Have you ever seen the circumflex go down?
Never seen the circumflex go down from it. It's usually beyond the circumflex, and I think, the radial strength of it, I should have brought one with me, but they're not that, it's not that aggressive, the amount of radial strength that comes off it. It's fairly malleable, and I don't think it'd be likely to block off the circ. We do worry about that sort of thing as well, but no, it's not been a big issue in the case reports. The main complications are tamponade. If that happens, it's usually because you've perforated the left atrial appendage, and it's best to actually deploy the device and put it in, even though it seems like the wrong thing to do. I've just perforated something, then I go and stick a device in there. But as you saw from those earlier pictures where I showed the device going in, and you could see there was no contrast going through it, pretty much as soon as it was deployed. Often, if you have caused a little perforation in the appendage, if you put the device in, it'll stop it from bleeding. So put the device in, put a pigtail catheter into the pericardium, drain it, and you can actually auto-transfuse the blood back into the femoral vein if it's coming out at a rapid rate, and then wait. And in the trial, they had about a 2% risk of tamponade, which was high. Although that was the first in world, if you know what I mean, that was the first 150 cases that were done. I think it should get better. The other thing is there's a newer device that's coming that doesn't have the same sharp ends on it, so they are modifying the shape of it to try and minimise that. The newer devices, there's a new one coming in the next 12 months which has a closed end on it. Instead of the feet just sticking out and being sharp, pointy things, the feet stick out and then join to each other, so there's no sharp, pointy bits. And the St. Jude device, which is a cardiac plug, has got sort of a cylindrical type of device that sits in the appendage, and then a plug that sits over the outside. So again, it's softer and doesn't have pointy bits. So I think all these refinements will hopefully reduce the tamponade rate. But that's the main complication I explain to patients, and it's the main one we've actually. Thank you very much.
Swirling horses throw you high.